It's my pleasure today to highlight the most recent publications in the field of nephrology under exciting title Journal Club. First of all, I would like to thank and appreciate the full support of Professor Sobh and the great collaboration done by my great brothers, Dr. Hussein Sheashaa and Dr. Tariq Tantab, for preparation of the Dakar Nephrology group meeting this week. The corners of this journal club will include 9 corners. I'll start with applied acid-base disturbance corner, followed by basic research and acute kidney injury, chronic kidney disease and dialysis corner, glomerulonephritis corner, immunology and renal transplantation, infection control, nephrology, pharmaconephrology, and I'll end with poisoning. So to start with, this is one of the most recent publications discussing the metabolic acidosis of chronic kidney disease, an update, and this table summarizes the net endogenous acid production. The net endogenous acid production equal hydrogen derived from metabolism of ingested proteins minus bicarbonate derived from metabolism of ingested organic acid anions minus organic acid anion lost in the urine. So factors affecting net endogenous acid productions include type and quantity of protein ingested. So protein increases acid. Type and quantity of fruits and vegetables ingested, because fruits and vegetables increase bases and alkali. Type and quantity of organic acid anion excreted, acid-base status, and proximal tubular function. This is a very important point. The adverse effects in metabolic acidosis in chronic kidney disease. Metabolic acidosis increased degradation of muscle protein with muscle wasting and suppression of growth in children. So it leads to malnutrition and loss of the muscle power, dissolution of bone and bone disease to buffer the acidosis, decrease the albumin synthesis with predisposition to hypoalbuminemia and malnutrition. And so if we find a patient on dialysis with malnutrition and metabolic acidosis, we should correct metabolic acidosis, because metabolic acidosis leads to hypercatabolic state leading to malnutrition. It increases the risk of progression of chronic kidney disease, stimulate inflammation, and we know that inflammation is one of the key players causing deaths for dialysis patients. Impair of insulin secretion and responsiveness, increasing resistance, stimulation of amyloid accumulation, and increased risk of death. So metabolic acidosis is very important to be known, and we should think of metabolic acidosis while we are following up patients with chronic kidney disease, because the majority of nephrologists concentrate on blood pressure and neglect blood gases. So here I'm not intending to advise for arterial blood gases every visit. No, just venous bicar to monitor the acidosis, and if we find acidosis, we should correct acidosis, and I'll mention how to correct and to what extent the correction should be. So the question, why metabolic acidosis leads to chronic kidney disease progression? If we say chronic kidney disease means that glomerular filtration rate decreases, it leads to hydrogen ion retention, leading to decreasing interstitial pH and intracellular pH. And this at the end of the day leads to interstitial fibrosis. How? Because this imbalance leads to increasing angiotensin-aldosterone pathway, increasing endothelin, increased pro-inflammatory cytokines and chemokines, increasing NH3 with activation of complement. For all these molecular mechanisms, metabolic acidosis lead to interstitial fibrosis. How to treat? We have different forms, either modification of the foods, and we should put in mind that foods rich in protein leads to increase the risk of acidosis, and foods rich in fruits and vegetables are good because it decreases acidosis, increase to the alkali side. We may treat with sodium bicarb tablets. Here, if we are dealing with advanced chronic kidney disease, we should take care of hyperkalemia. But if we start in the early stages, stage 1 and 2, this may be of help, and there are a lot of studies showing that fruits and vegetables are equivalent to sodium bicarb tablets and treatment. Here, sodium bicarb tablets from 300 to 650 milligram per tablets, and this is the metabolic equivalence in milli equivalent per tablets, 3.7 to 8, inexpensive and easy to administer, result in generation of gas in the stomach. This is side effects might be uncomfortable for patient. Enteric-coated bicarb tablets like this form, and we should look at the contents. And this is enteric coating protects tablet against acidity, allowing more base to reach intestine. Use cautiously in patients with severe chronic kidney disease. Enteric coated tablets or capsule available in Europe. Shoal solution, each 1 milliliter of solution contain 1 milliequivalent of base equivalent, can increase aluminum absorption. Fruits and vegetables, quantity designed to provide 50% of acid load, effective in controlled studies, provides calories and potentially significant potassium load, so we should be careful in advanced chronic kidney disease. Phosphate binders, we have phosphate binders, acetate and citrate provide base that will affect quantity of endogenous base required. Both acidic and basic form of sevelamer are available. The acidic formulation with hydrogen chloride tends to lower serum bicarb concentration, whereas the basic form with carbonate tend to increase it. This is the most easy form. We should first calculate bicarbonate requirement. So we have venous bicarb. So we have the desired serum, we determine the desired serum bicarb, and for simplicity, we should consider 24 milliequivalent per liter is the desired form. And we have the actual serum bicarbonate. So if we say the actual is 20 and we need it to be 24, so 24 minus 20 equal 4. And bicarb is distributed in the body water. It's approximately 50% of body weight. So if the deficit is 4 multiplied by 50% of body weight, this will give us the total amount of bicarb needed. Administer sufficient base to increase serum bicarb concentration to 24, as I mentioned, and administer this dose over 3 to 4 days while monitoring serum bicarb concentration. When serum bicarbonate concentration reaches target of 24, reduce the dose of base with goal of maintaining serum bicarb at or less than 24. From 22 to 24, it is the best values, because we don't like acidosis because of all side effects that I mentioned, and we don't like as well alkalosis to induce alkalemia or alkalosis, because induction of alkalosis lead to vascular calcification and excess mortality. Consider more aggressive base replacement in chronic kidney disease patients with disorders associated with base loss, such as profuse diarrhea or generation of large acid loads, such as ketoacidosis. Suppose that we have patient on dialysis, and despite the dialysis bicarb, the use of bicarb dialysis, the patient is still acidotic. How can we do? What we can do, we should be sure that the dialysis is in optimum dose, and then we should give the patient supplement of bicarb to reach 22 before dialysis and just less than 26 at the end of dialysis session. The basic research corner. Here, this is one of the exciting articles because it shows advances in generating and maintaining nephron progenitors and the development of nephrons. So this is from the embryonic stem cell or inducible pluripotent stem cell. Here you can find the nephron progenitor, and this is the development. And this small review, the author mentioned that nephron in 2015, nephron progenitors age during development in vivo, but all the progenitors can be rejuvenated, and this is very exciting. How to shift the old to young by rejuvenation when surrounded by young progenitors. Nephron progenitors can be expanded in vitro beyond their physiological lifespan. Kidney organoids containing multiple lineage can be induced from human-induced potent stem cells in vitro. Very interesting for me, this alternative splicing in chronic kidney disease. What's meant by alternative splicing? Normally, we have DNA that include genes. We have approximately 20,000 genes. And these 20,000 genes leads to formation of 100,000 proteins. And as we know that the DNA leads to formation of from the DNA there is pre-mRNA. And from pre-mRNA, the final form of messenger RNA is formed, and this messenger RNA leaves the nucleus to the ribosomes in cytoplasm, leading to protein formation. If each gene leads to special mRNA that guide the ribosome for certain proteins, so I am expecting that the total number of the gene lead to the same sum of protein. But what happens? During evolutions of pre-mRNA to mRNA, there is splicing. Splicing means this is the sequence, this is exon, and the exons are expressed to protein, and the introns are inert, separating the exons. So what happens in the splicing is to remove these introns, leading to the exons, and the exons lead to polypeptide formation from ribosomes and the formation of protein. And for the spliceosome, this is a machinery form that leads to splicing. Here, this is splicing factors, and we have either exon or introns. Exon splicing enhancer, this leads to more enhancing splicing. Intron splicing sequence silence. So this is exon sequence enhancer, and this is intron silence. So the balance between all these lead to splicing of exons, and the exons lead to protein. If there is different cut at different areas from the in the mRNA, this will lead to different forms of protein that may have different function. Up to date, we have more than 370 diseases related to abnormality in the splicing of these genes. In chronic kidney disease, we have examples. This is vascular endothelial growth factor protein. We have either angiogenic forms or anti-angiogenic form. Angiogenic form, it is VGF followed by the number of amino acids, and all these are A form. If there is proximal splicing selection, in the distal splicing site selection, we will have B. There is in the glomeruli, there is balance between B and A, so there is in the healthy glomeruli there is no problem. But when the A increases, this will tip the reaction toward chronic kidney disease and damage. And the same for the vascular endothelial growth factor receptors, also for soluble clotho, and we know that clotho is responsible for keeping the kidney, and it is anti-aging and antioxidant, and so we may have different forms according to the splicing. And the alternative splicing for the erythropoietin receptor may lead to a form of receptor that is resistant to the action of erythropoietin, and fibronectin for different form can lead to chronic kidney disease. Is there a potential therapy for this issue, for the alternative splicing? Yes, we have now splicing switching oligonucleotide that binds to exons or introns and guide splicing toward a special entity, and this is kinase inhibitor, inhibition of splicing kinase. In this site, we have what's known as Sphinx, and there are human studies in the use of this kinase inhibitors. Either we may have this kinase inhibitor or modulators of protein-protein interaction at splice site, or modulators of splice factor RNA interactions, or modulator of tertiary RNA structure at the splice site. Another article in the basic research for cisplatin nephrotoxicity, because they reached the novel of histone deacetylase inhibitors to protect against cisplatin nephrotoxicity. So cisplatin upregulate this HIDAS 136, and if we use HIDAS inhibitors, this may attenuate the cisplatin nephrotoxicity, and this may be through the inhibition of this pathway or leading to formation of protein known as EUMAB protein. So this is an interesting issue, and it is shown here clearly in this basic experiment. Here the kidneys are healthy. Here a lot of coronary changes, and here after application of the drug everything is fine. Another issue is this article, which is very stimulative, kidney on a chip technology for drug-induced nephrotoxicity screening. And instead of waiting until the patient receives the drug, we can test the nephrotoxicity in this chip. This is proximal convertibles and different transmitters, and we can apply the drug ex vivo, and then we can expect the nephrotoxicity and avoid the nephrotoxicity of the drug. So I think it's very exciting. Other work in the polycystic kidney disease. This is rats, a special rat model, mice model for autosomal dominant polycystic kidney disease. This is the mice fed on the regular diet, and this is calorie restriction diet. You can here see the great difference in the size of the kidney and the cyst. And this is an hematoxylin stain of the mice fed on the ordinary diet. This is the kidney increase in size, and this is after food restriction. Again, the CKD and dialysis corner is one of the exciting, how to measure residual kidney function in dialysis patients without urine collection, because urine collection is difficult and cumbersome sometimes. So we have now equation that predict the residual kidney function, and we know that if the dialysis patient has residual kidney function, this is a very good issue, and the loss of residual kidney function is associated with increased mortality. And this is one of the calculator. If you just put on Google if you put this site, you find asking you if there is residual kidney function. The patient has urine output exceeding 1 cup, 250 milliliter. If yes, then you will be asked to put the value of B-trace protein, and if you just here, this is the value, and this is this sex, male or female. Calculate, will find here the value of GFR. Iron deficiency anemia is one of the important corners in treating dialysis patients, and this is the evolution of iron through the years. So the early 80s, what we had at the time, ferrous salts and iron extra intravenous form, and then through the years here in 2000 iron sucrose, then fromoxetol in 2009, then ferric carboxymaltose, ferric citrate in 2014, and on 2015 ferric pyrophosphate citrate added to dialysis solution. So this is the CROSS 1 and CROSS 2. These studies include 599 patients followed up for 48 weeks. All forms of iron were discontinued before they started the study, and one group is randomized to dialysate containing this form of iron, ferric pyrophosphate citrate, on a certain level, and then the patients and the other group ranked as control without supplementation. And here in this study, there is a good proof that the ferric pyrophosphate citrate is physiological to control the correction of iron deficiency and decrease the need for ESA therapy. And I think it will be in near future available to treat iron deficiency by just using forms of dialysate that best fit for these patients. Phosphorus control, as you know, there's chronic kidneys and phosphorus. Phosphorus is very silly, and it's one of the key players in causing cardiovascular related deaths and vascular calcification. And here this article discusses the hyperphosphatemia in dialysis patients beyond non-adherence to diet and the binder. And here there are a lot of threats that make the control of phosphorus difficult control. And these threats include inadequate dialysis, or even if dialysis is adequate, the lower clearance of phosphorus by dialysis, and increased absorption from the diet, and low efficacy of the phosphate binders. And if you add patient non-adherence, this leads to more and more difficulty in control. So we are waiting the combined study. What is the rationale of combined study? Is to combine lansinium carbonate plus nicotinamide in a testing study. Why here they use nicotinamide? Because absorption of phosphorus is either paracellular from the intestine, is paracellular, and this is passive. So if you restrict phosphorus or even give phosphate binder, you will decrease the paracellular, and this will stimulate the transcellular co-transporter sodium phosphate and leading to absorption of phosphorus from transcellular. So the aim of nicotinamide is to inhibit this co-transporter, and this will lead to potent phosphate control and even leading to decreasing of FGF23. And this is one of our initiative, Dr. Dua, our dietitian consultant. This is a very innovative tool, and this is a modification from the Italian pyramid. Here we have multiple pyramids from Egyptian foods, and here at the base of the triangle it is safe food, and at the top it is not safe. Regarding levocarnitine in hemodialysis, is a randomized control study showing that levocarnitine is useful and is associated with increasing ejection fraction and lowering left ventricular hypertrophy. But be careful, because here before giving levocarnitine, they measured the level and they found the patients are deficient in this levocarnitine. Treatment of IgA nephropathy, the current literatures are frustrating, and this is the title: immune suppression in IgA nephropathy. How certain are we? If you look to the wisdom of this discussion, here they are supporting supportive therapy in IgA nephropathy based on recommendations of the STOP IgA in the trial, and this is the intensive supportive care plus immunosuppression IgA nephropathy, showed that blood pressure should be controlled, ACE inhibitor or ARBs with up titration of dosage, sodium restriction is essential, control dietary proteins, consider a statin, control each component of metabolic syndrome, aldosterone antagonist therapy if proteinuria is not controlled with ACE inhibitor or ARB, possibly add a diuretic to avoid hyperkalemia, smoking cessation, avoid non-steroidal, or administer no more than once or twice weekly. After all these supportive treatment, if you still find the patient with proteinuria above 3 grams, you may start steroid only according to this discussion. So again, the use of immunosuppressive in IgA nephropathy is currently limited and based on low evidence. Regarding the immunology, here this is very nice. This is a very nice article. It showed that we have two types of macrophage, M1 and M2. M1 macrophage lies in the cortex, and this is inflammatory, and M2 is anti-inflammatory and lies in the medulla. So this is why we find the rejection nephritis in the cortex rather than in the medulla. This is one of the important cases in the quiz. A 39-year-old black woman received a living-related donor kidney transplant approximately 18 months ago. The course was fine except of rejection. One attack of rejection treated with steroid, but the condition is complicated with severe hypertension and hyperkalemia. The current medication include tacrolimus 2 mg twice daily, prednisolone 7.5 mg daily, MMF 1 gram twice daily, sulfamethoxazole trimesoprim 480 mg 3 times per week, amlodipine 10 mg daily, carvedilol 25 mg twice daily, omeprazole 20 mg, and pravastatin 20 mg. On the initial evaluation, the patient is hypertensive, potassium is 6.1 milliequivalent per liter, creatinine 1.7. What is the action you may recommend? Here, they stop sulfamethoxazole trimesoprim and they give the patient Kexalate, and then after 2 weeks, the patient came back with 6.5 milliequivalent potassium. So the question is, which of the following mechanism is involved in the development of hyperkalemia and hypertension in this patient? Depressed GFR, chronic metabolic acidosis, upregulation of sodium chloride co-transporter in the distal tubule, upregulation of aldosterone receptor in the distal tubule, corticosteroid-induced suppression of aldosterone synthesis. The answer is the C, which is upregulation of sodium chloride cotransporter in distal tubule. Why? Because tacrolimus, this is a calcineurin inhibitor side effects, because tacrolimus stimulates sodium chloride cotransporter in distal convoluted tubule, and this leads to salt-sensitive hypertension to increase sodium reabsorption. If sodium absorption increases through distal convoluted tubule, so the sodium flow to the distal, to the collecting tubule decreases. This leads to, and as you know, sodium is responsible for potassium secretion. So if sodium secretion to the collecting tubule decreases, potassium secretion decreases, because these mechanisms are inhibited. So this, at the end of the day, tacrolimus through stimulation of sodium chloride cotransporter in the distal convoluted tubule lead to hypertension and hyperkalemia. So the treatment here, it's rational to use thiazide, because thiazide is specific for the this cotransporter. Regarding the infection control, the effect of copper, this is a very interesting, because if they compared the growth of bacteria on the copper surfaces versus the control in the so they tested the bacteria over the handle, cradle, and the bed, and as you see, the green means the bacteria are below detection. So here, in comparison to the copper control surface, the bacteria growth over the control surface are significantly higher than the copper surface. So copper surface are associated with significantly lower concentration of bacteria on selected surfaces within a pediatric intensive care unit, and it's the time to revise the approach to registering antimicrobial agent for healthcare setting by using the surface continuous reduced bacterial contamination. Through the radiology, you can find, through this cover of the journal, you can find by the radiology they can go to all segments of the kidney. And another interesting advances in MRI is the development of automated segmentation, MRI augmented segmentation, to allow accurate measurement of and easy measurement of polycystic kidney disease, and to follow it accurately. And by another Mayo Clinic, they find the same. Regarding the pharmacology, this is very interesting, because inappropriate medication is relatively not uncommon. Here, this is 13% of the patients either taking medications that are contraindicated or inappropriately dosed in these patients. So we should know the drugs which are contraindicated and drug which needs modification. Another issue regarding the use of phosphate enema, sodium phosphate enema, in laxation before colonoscopy. And this study, which included large number of patients, showed that the use of enema is not without side effects and may be associated with reduction of GFR. So we should look at the bowel cleaning when we think of colonoscopy. The side effects of proton pump inhibitors include small bowel bacterial overgrowth, infections, Clostridium difficile infection, Salmonella, Campylobacter jejuni, upper respiratory tract infection, lower respiratory tract infection, like community acquired pneumonia, hospital acquired pneumonia, ventilation acquired pneumonia, associated pneumonia, celiac disease, found gastric polyp, rebound acidic hypersecretion or breakthrough hyperacidity, calcium malabsorption, bone mineral density. A lot of publications showed that the use of proton pump inhibitor may increase fractures, vitamin C and vitamin 12 malabsorption, hypomagnesemia, especially for those patients receiving this drug for more than 3 months, and especially if they used diuretics like thiazide or loop diuretics, may be associated to increasing myocardial infarction and interstitial nephritis. So the wisdom is we shouldn't use these drugs except if there is an indication. Regarding metformin, this is one of interesting studies because they used metformin 3 gram versus placebo to treat pregnant ladies beyond the first trimester. This study included 200 patients allocated to metformin and 198 allocated to control group, and this is a randomized controlled double-blind study. And the rationale was to use metformin to test its capability to reduce the body mass of the baby born to mothers who are not diabetic but have body mass index above 35 kilogram per square meter. And at the end of the study, they found that the mothers received metformin have less gain in weight, but the babies, there is no difference in the weight of the babies. And there is some side effects related to metformin. This is the another interesting study is Fourier, the abbreviation, rationale, and design of the further cardiovascular outcomes research with PCSK9 inhibition. What's PCSK9? It is proprotein, convertase, subtilisin, cysteine. This protein is related to degradation of LDL receptor. So if we have severe hypercholesterolemia, and we give the drug that inhibit this protein, we may keep LDL receptor. So this is the rationale of the use of this class of drugs. One of these drugs is human mononuclear antibodies given either 140 milligram every 2 weeks subcutaneously or 420 milligram every month subcutaneously. Look at the number of patients in the study and the control group, 13,000, a big study, and we are waiting the result of this study. Regarding poisoning, this is an example of the poisoning, the use of extracorporeal treatment for management of poison. When we deal with any drug, we should know the molecular mass, bioavailability, protein binding. This is in phenytoin 90%, although it's 90%, but it is moderately dialysable. Volume distribution, this low volume distribution, because if you find even if there is a large volume distribution like digoxin, although digoxin is dialysable, but dialysis is not efficient to detoxify digoxin. Why? Because even if you remove the tiny fraction present in the blood, rebound will occur after the end of dialysis, so dialysis is not efficient because of volume distribution in digoxin. So to take care and get rid of digitized intoxication, febfragmin is interesting because it leads to shifting of digoxin to the blood, and you can remove this complex by plasma exchange. Here, although the protein binding is 90%, but it's moderately dialysable, and here, and this is the consensus guideline, the extracorporeal treatment will be reasonable in selected cases of severe Phenytoin poisoning, and it is suggested if prolonged coma is present, should be discontinued when clinical improvement is apparent. Regarding the anion gap, it is the difference between sodium and chloride and bicarb. And this is a typical example of sodium 140, chloride 15, bicarb 25. So this means anion gap is 10. Here, if the patient is intoxicated with bromide, what happens? Bromide is an ion. So if we think of an ion and add it to the blood, we may think of higher anion gap, because 10 should be added to anion gap, so it should be 20 in a regular fashion. But what happens? The bromide is read as chloride, and each 1 millimole of bromide is read by more than 2 to 5 milli equivalent by chloride. So here chloride is very high, and pseudo hyperkalemia leading to negative anion gap. So negative anion gap may be a clue for bromide intoxication. Again, we know salicylate is the cause of high anion gap acidosis, but sometimes if you have patient come into the emergency department comatose, and you find him acidotic, and then you calculate anion gap and you find it negative, you may think also of salicylate intoxication. Why? Because if you use this method, read this salicylate as chloride, so it's lead to pseudo hyperkalemia. And the same with this, but if you have CX3 delta indirect ISE, this may give the correct chloride form. So again, negative anion gap may be a clue. Negative anion gap in the presence of acidosis may be a clue for salicylate intoxication. And these are the causes of negative anion gap. You can fix the slides and read it in details. At the end of this presentation, we should read every moment. And more than reading is to be wise in approach. So knowledge It is a dwelling of your brain by the other activities, by the other persons. But wisdom, it's your own. And the knowledgeable person may be proud by the knowledge, but the wise person is humble because his knowledge is limited to this point. So don't forget the 3 R's. We should respect for self, respect for others, and we should be responsible for all our actions. And thank you very much for your good attention. At the end of this presentation, I acknowledge the collaboration of Dr. Osama and Dr. Tariq for organization of the meeting and hoping the best for all of you. Thank you very much.